Joe Feinglass has over 20 years experience in health services and health policy, including work in quality improvement, patient outcomes, medical informatics, cost effectiveness, and social epidemiology. With over 180 peer-reviewed publications, he teaches in the Masters in Public Health program and is a board member of the Chicago-based Health and Medicine Policy Research Group. Come on up, Joe.
I wanted to thank the people for inviting me today who are on the committee, because this was actually something that was a bit of a odd experience for me of seeing the Zar Symposium online. Someone sent it to me as an email. And when I saw it was on open data and I began reading about it, I thought, wow, this is really cool. And I hadn't really thought that much about librarians and their role in social change in the United States in general, and the whole issue of being data scientists now that all of you have. So I'm going to try to tailor the talk more to that as we go along, and I kind of made it into I'll have to go through my slides very rapidly because they're much more in the context of a traditional health services research study. But this was a study that was based on open data, and I'm not going to be able to explain every aspect of it, but one of the key things here was the ability to get to two data sets. One was a data set that had to do with Illinois hospital emergency room visits and outpatient visits and admissions that existed for many, many years. This is a 20th century data set, which I had used, way at the beginning of my career. We had the Illinois Hospital Cost Containment Commission maintain this, and it was a government regulatory thing that said you had to submit data if you were Illinois hospital to the IDPH. So the Illinois Hospital Association, in their wisdom, decided to spin off a version of what they're sending to IDPH and sell it to the public, right? But meanwhile, as a member hospital, Northwestern Memorial Hospital, I'm able to get Illinois hospital claims data for the state of Illinois with identified hospitals. Patients are de-identified, so there's no ability to link individual identifiers of a patient, for instance, has been readmitted. You can't look at that. But you can look at admissions and visits, and you can look at it from the standpoint of identified Illinois hospitals. So that was data set number one. Data set number two was the US Census, and we'll talk about that in a minute as to this use of our use of census data. And it's so often the case in our area in health services, the whole definition of creativity is you get two data sets and you link them and then you write an article about it. Or you get a grant to link two data sets and so forth. And that's kind of been the paradigm for maybe 15 or 20 years. And it's just this idea that you find out something different if you start linking data. Now, having said that, the background of the study itself is that I've spent years with other researchers at Northwestern looking at the effects of health insurance on health. And I'm not going to have time to go into that here today. But it was, we thought, kind of a settled issue at one point that, yes, it's actually not only a financially great thing to have insurance, but it actually protects your health and less people die, especially age 18 to 64 people who are subject to not being eligible for Medicare. They die because of lack of health insurance. But it turns out to be a super complicated thing that has to do with people coming in and out of being insured, and the exposure isn't clear. You know, people lose a job, get a job, they're insured, they're uninsured. But putting that all aside, when the ACA came, I thought, well, geez, you know, who's going to study this in Illinois? Who's going to study this in Chicago? Because I'll tell you, no one is going to study it. Because if it's not me, somebody that I've had the kind of research background of mine, I wasn't sure who was going to do it. So this then blended into a second line of research that had to do with the role of the emergency room in our healthcare system. And again, too much information here, but the upshot being that there's been this, you know, continuous growth in emergency room visits that's sort of inexorable, hospital emergency rooms. So we don't know all of the reasons for it, and it's very interesting that it hasn't really been studied that closely, but we know that the rate per capita continues to go up, and it has absolutely no effect opening these quick access centers. So the upshot was that, you know, in fact, we find that the, you know, those immediate care, urgent care things have absolutely no correlation with the growth of emergency rooms in the same places. So this has been another side of this. And then finally, I think that many of us, like myself, are working on issues having to do with these very high cost, very sick patients who run up millions of dollars in bills and have frequent ED visits because they're having poor relationship with their primary care doctor, or they don't get home visits is really what a lot of it is. So these are the kind of research agenda thing that brought me into it. But going back to 2010 when this project started, we're going, oh yeah, Obamacare is coming. We know that there's going to be the ACA health insurance expansions. And at that time in Illinois, this was a substantial chunk of the population, particularly those who are under age 65 and over age 18. So this is the kind of thing that we were facing in 2010 when we first thought, oh, we should figure out how to study what's the effect of the ACA going to be on healthcare use and on health. So again, a little bit of a switching of gears here. Emergency rooms are not the best place to get primary care. Hawkins may disagree with this in the back of the room here, who's a Northwestern resident, but actually, you don't necessarily want people to come there unless they're really sick, but they're also very crowded, and particularly in Chicago, we have a lot of trauma and so forth. And we also know that Medicaid patients are the ones who visit the ED the most. So this is the National Health Interview Survey, and again, if anyone wants my slides, I can send them to them. You just give me your card and I'll send you the slides. And there's more where these came from. But the idea is that everyone kind of already knew that Medicaid patients are the ones that cause the most emergency room visits per capita. And you can see here from the National Health Interview Survey, again, a public data set that has been used for this purpose, kind of the difference by insurance status. So our goal was to try to track emergency room visits by insurance status. Now, when you look at why Medicaid patients don't get in to see their doctor or have waiting too long or they have all of these barriers are much more common with those with Medicaid compared to private insurance. And Medicaid, there's reasons why people don't get good primary care. We can get another way too long, complicated conversation. But we know that Medicaid patients before the ACA were a large portion of emergency room visits. So the theory was, at the time that we began this study, that when you expand Medicaid in Illinois and you open it up to people who are childless adults, there's going to be a big initial spike in emergency room visits as people basically now you can go to the emergency room and you don't have a collection agency that gets on you to collect your $2,500 that you owe for that emergency room visit. You'll go to the emergency room and find out what's wrong with you. So then there was an assumption that, well, then they get primary care, they get put into a system of care, and people start to get used to their primary care doctor and it'll taper off. So that's one theory. There was an alternative theory at the time from the Oregon health insurance experiment. I don't even want to get into this. This was a crazy study based on a lottery to get Medicaid insurance in Oregon, and it was sort of a natural experiment. So these Harvard economists loved this, and it became this huge discussion. And but there you can see that the people who won the lottery, who are called Medicaid in this slide, continuously had higher emergency room from then on, for a 2-year period that they followed them. So, having that set up, we decided to put together these two databases. These are some of the basic statistics about the data. We had 15.2 million ED visits in the time period that we looked at initially, which was 2011 to 2015. 2014, January 2014 was our date for initiation of the ACA. There's a little bit of an off thing in Chicago where there was a waiver with Cook County Hospital, and we don't need to get into this, but the upshot was we have kind of a time thing where pre-post. There was this Medicaid expansion that began really in the fall in county care here in Cook County, but then expanded to the state in 2014. And we used the two data sets. Numerator is hospital visits, and we'll talk about this in a minute, at the zip code level for that patient. The denominator is the ACA American Community Survey, which, as many of you know, is the census data. We used annual American Community Survey, so we could adjust it for each of the years as we went through the period when the ACA kicked in. And we therefore could calculate numerator denominator for each insurance status. And I'll continue to explain this, but I wanted to pay tribute to my good buddy, Kelsey, who was the crucial person when I was sort of wavering in whether it was worth cleaning 15.2 million records to get maybe like one paper out of it, and I'm already like a professor, so it wouldn't help me anyway. Kelsey was my man, and he really helped me psychologically as well as in terms of being a resource person, and did all the mapping for this project. And he couldn't be here today, but if any of you know him, tell him I mentioned him. So the American Community Survey, very quickly, they ask you questions about your insurance status. There's some imputation going on about what's primary when you do more than one, but that's a minor problem. And it's been used to determine insurance coverage in the United States for a long time, among other things. And lo and behold, this is the slide that speaks 10,000 words. And looking at 2012 to 2015 here, you see 600 and some thousand people that used to be uninsured are now insured in Illinois. So this is the Pat Quinn administration legacy to the state of Illinois that's now under some very interesting questions as to what's going to go forward in Washington. On the other hand, Medicaid, as you see, grew by 300,000. So you have this big increase in Medicaid as people come off uninsurance, some additional private that are the exchange people that go on the exchange and get their policy and so forth. And again, not a lot of time to talk about this, but this is fascinating and very relevant to the policy debate now. We did what's called interrupted time series. I don't want to get into this much, but it was the idea of a counterfactual trend. If you have emergency room visits increasing anyway, you can't do pre-post because they were going to be going up and they'd be higher in the period after 2014 no matter what. So what we do is we look at the slope of the lines, and yes, Medicaid is the purple line that you see jumping up there, and the uninsured are the red line that you see going down, and these are their rates. And we published this in Annals of Emergency Medicine, saying yes, the ACA increased emergency room use in Illinois. We looked at the uninsured, they fell quite significantly. So this is an interesting phenomenon at places like Cook County Hospital. So again, interrupted time series would tell you this is a significant difference in the slope of increase of the uninsured visit rate. And places like county went from 25% insured to 75, 80, 90% insured in like 2 years, and now get revenue for all those patients that were previously free care. On the other hand, they're cutting all the disproportionate share money for our inner city hospitals. So we at Health and Medicine Policy Research Group are very concerned about what's the safety net implications of some of this. And I'll get into that more in a minute. So the study that really I have a few more minutes left, I think, to tell you about is using public use micro areas, which are smaller areas in the state of Illinois. There are 88 of them with about, in the case of the 18 to 64 population, it's a 90,000 person average. And so this is a new census thing that we were able to use since the early 2000s, or 2010s. And Kelsey helped me with this, and we mapped the zip code level hospital data to the PUMA level data, which we could do because of, again, this is where librarians come in and become huge. By the way, this is what a PUMA looks like. It's a kind of a fairly large area, but in this case, you can see it's Lower West Side, South Lawn, and so forth. That's a PUMA, and these are different Chicago area PUMAs, and then there's 88 of them across the state. But we went to this Missouri data center. So this was really cool. And maybe you guys have used this. Has anybody here used the Missouri data center? I'm sure you have, right? And so what we got from this was the proportion of people in each census zip code tabulation area that are living in a particular PUMA. So we knew that if there was 100 discharges in a particular zip code, how to attribute them to the adjacent PUMAs when there was boundary crossing, which had been a problem and no one had apparently figured out how to solve before this. So this is where I get like, the Nobel Prize in Health Services Research for finding this website. And lo and behold, what was really interesting to me, and again, I want to try to leave time for discussion, there was such a vast difference by what neighborhood, and I mean, so 70% had private, but 32% in Lawndale did not have private insurance. 32% was the number of private in Lawndale, 42% are uninsured in that PUMA. So this is like lifetimes away. Western Kane County, 90%, so that the ACA doesn't affect Kane County, right? So that's the interesting political message that I got out of these data, was that the ACA is all about, 2% of my neighborhood, the new North Loop and the near South Side where Feinberg is, had Medicaid, but 30% of people in Englewood had Medicaid. So this is the kind of thing that why this issue is such a divisive issue in our country, in my opinion. So I've often thought, why do conservatives hate the ACA so much? One of the reasons I think is it's the new form of welfare where the undeserving are getting all the benefits. This was Kelsey's mapping that he did. I'm not going to spend much time on this right now, but we looked at changes in population. We looked at changes in coverage by like which areas had gains in Medicaid insurance and so forth. And we found that there was a lot of change in insurance status in some of these areas, like 20,000 people in some of these PUMAs went from uninsured to insured, but very concentrated effects. Again, dividing the country where some areas of the country, ACA has no effect on them. And it's a redistribution of wealth. Make no doubt about it, Obamacare, as we've known it, is the biggest redistribution of wealth in American history, I think, including the earned income tax credit. Another fascinating finding was the variation in the underlying rate before the ACA in the actual ED visit rate. And again, a picture tells 1,000 words. I'm not going to be able to go into it, but there's a lot of reasons why areas, what was the lowest rate was forgot, the second lowest rate was New Trier Township. The first lowest rate was, Lincoln Park had the lowest ED visit rate in the state of Illinois. And then, out there are the neighborhoods out on the southwest side. So quick results, and I'm not going to have time for much of this, but the rates went up, the total numbers went up, and then if you look at the 88 areas graphed against the change in the Medicaid ED visit rate, calculated with a denominator of Medicare enrollees of that age and a numerator of the number of ED visits where the primary payer is Medicaid, this is what you see, with a huge increase in some neighborhoods and virtually nothing happening in others, as predicted. So that's kind of the conclusion here. I'll stop. One of the things is that, there's a lot of things that could potentially come out of this. One of the things I was just talking about in the hallway, though, is this is a classic example where no one's going to pay me now to keep this data set together. So I'm not going to want to work on this anymore because I'm not getting any grant funding. So it's just going to get archived off, right? I'm going to put it on my archives, and it's going to, maybe in 2 years, somebody's going to ask me, oh yeah, how did I calculate the rate for this? And I have some code, and I've saved my SPSS or my Stata code or whatever. But it's like the chances of this ever being used again are minimal, the way my business usually works, because there's no economic incentive for me to do all this programming and put the 2016 data into this. So that's an interesting one that I'd love to get your thoughts about. Last thing I wanted to comment about was this may be saving people's lives. So one of the studies at Northwestern by the economists there looked at distance to the emergency room as from the centroid of a zip code where they knew that they had a proprietary hospital system database. It's not the same thing as mine. But they looked at a big set of hospitals in expansion states, non-expansion states. And one of the things they found in the expansion states was that people go to the nearest emergency room that didn't used to. So the travel distance drops as a result of these new Medicaid enrollees who are going to the emergency room that's closest to their house now. Then you look at what they went there for, and you can look at what we call non-discretionary reasons that people go to the emergency room as opposed to sort of ambulatory care sensitive conditions. And there's a lot of these things that people should have gone to the emergency room, and they did. And so you're kind of wondering, maybe that explains what we have found, that there is a death rate difference, like after Romney Care in Massachusetts, you compare Massachusetts counties to other counties, very, very similar counties in the rest of the United States. The 18 to 64 population has a death rate advantage at the county death certificate level. So part of it may be better access to emergency care. I don't know. This is not, I'm speculating. And then lastly, this is my what's coming with Trump Care as far as the policy options that are going to be available to a lot of the people that we care about. And then this is our research team. So thank you. And I know I went through that fast. If anybody has questions, hopefully we'll have time.
Yeah, so we have about 10 minutes for questions, actually, so open it up to questions. Yes.
You said you archived all of your SPSS and Stata code.
Of course.
Is it archived in a way where anyone in the world can discover it?
It's my again, talking to somebody who's done this for like over 20 years, it's got my little comments in there where I gray out a comment that says, here's where you do this, or here's where you do this. But no, it's not meant to be given to anyone else to use. And truthfully, I don't think it would be possible really to have someone else come in and, so I think I know where you're heading with this, but did you have any thoughts or?
Yeah, there's this website called GitHub, and it's where everybody puts their work so that the world can see it, and you would have to document it well enough so that someone with at least a partial intelligence that you have about that project could gain an understanding and pick it up.
So these data are on the social science computing network where I have my login and password that I use to get in to be able to do stuff. How is someone else going to get that? At Northwestern University, I guess they could. No,
I'll give you the microphone.
It's completely public data with totally de-identified. It's exempt from IRB,
So there are, first of all, there's the inter-university Consortium for Political and Social Research, which is a data archive that's been in existence for more than 50 years, hosted at the University of Michigan. You could deposit your data there. They would curate it. Northwestern is entering the data curation and repository world, so we have a repository where you could host your data there. So it would be off of, you'd have to let it go, though. You'd have to
no,
give
and I don't have any
give it
problem with
away.
letting it go. But I think the other issue that doesn't address, this GitHub thing doesn't address, is who's going to bring in the 2016 data, spend hours coding it into the format to use to add it to this data set, you know?
Presumably, if you have documented the coding that you did.
Well, somebody could do it, yeah.
Somebody could do it, but
and
you're
somebody
right.
could make a utility to make it a automated process, probably.
Right.
You know.
Right, but you're right. There isn't anyone who's
but no one's
going
paying
to
me to make a
annually
unless
update
National
it.
Library of Medicine wants to do it. I mean, somebody's got to pay me to be the programmer to do that, right?
So I think maybe what Ann was getting at, and the other gentleman, I didn't see who it was, is that if you do let it go and you are able to put it out there, especially if you put it on GitHub, you make it available so that you don't have to, people are willing to do this sort of thing without being paid. So if you put it out there, I'm not saying build it and they will come, but it's much more likely that somebody will find it and will add that data to it.
I'm sure you're right. And I guess what I'm wondering in my mind is, I'm being cynical here, but am I going to spend like maybe 5 hours to go through this and write in all the comments in my code that go back months and months and years, you know, and actually make this available to the public? Probably not. I'm not going to have those 5 hours to do it. And I'm going to work on the next data set that where I have to integrate 2 new data sets, you know.
So then spend those 5 hours in the beginning of your
Right.
next
That's
project.
Yeah, okay, that's fair
Right.
enough. No, I think you're absolutely right. I'm not disagreeing. I think that's a really good thing. It's not, again, in my generation, we just cranked these things out and we did the next project and the next project, and you just went on in your career and you left one thing and you worked on something else. And, you know, and that's why something I picked up here today from the discussion.
right. No, I agree with what Stephen mentioned, just maybe a change in your workflow and how you're doing it, and spending that time up front to put in all that, you know, what would be called documentation after the fact. Just build it into the workflow at the beginning. It's not quite as onerous, but a little more time consuming perhaps than what you're doing
this
now.
project could be done anywhere in the United States. So it's Illinois here because I live in Illinois. I'm interested in Illinois. I know the names of the hospitals. But in theory, the exact same hospital data sets exist in like 40-some states, you know. The National Inpatient Sample is an example. I mean, that's the format, but it's state hospital databases are in 45 states. Mm-hmm. And some of them, California and New York, are the fancy ones where they can actually have encrypted identifiers where you can see who are the frequent visitors, who are the people that come to the ED 57 times in that year, you know, and we can't get that from his. So maybe that's something Illinois would like to look into, but you'd have to get legislative authority to create an encrypted identifier, and, you know, that master patient index thing is a huge problem in healthcare.
We have time for another question or two if there are questions. Yeah.
So when you started this project, you looked at it, what's going to happen when the ACA affects healthcare. Is there anybody going to want to go the opposite way in the future and see what happens based on what we have after?
I like what you're saying because, truthfully, now's when you need the monitoring. And so, yes, I mean, we'll do that. You know, we're going to be geared up to do that. You know, it's interesting because sometimes things take a long time to have an effect. But, you know, in the example of the Romney Care thing, there were also 1990s and early 2000s state expansions of Medicaid where they increased it 25% in a state. And then they could look at county-level data to see very similarly matched, you know, again, there's no control group, but it's a very comparison group. It's very closely matched counties in the rest of the United States. And they found this huge mortality benefit, 6% difference over, I think it was a 7-year or 8-year something. So yes, we need to monitor what's going to happen. Will the government budget include funds for monitoring things like this? Will I get a grant from AHRQ to monitor that? I don't think there will be an AHRQ. You know, that's my personal belief, in that we're going to have to figure out some way to do this on the cheap. Because forget NIH funding all this health disparities research. That's done. you know, if the people at the top have their way. And, you know, that's just my opinion. And maybe we protest that, you know.
Hypothetical question, but hypothetically, if someone came to you with a fistful of money from wherever it is and said,
I'm
hey,
there.
this is really important, would you be, though? I mean, is that a question that you might anticipate in the consultation you have with your data services librarian, for instance?
You know, they don't know about grant funding, is what I've noticed, the librarians. They wouldn't know about, like, where would you submit this to get money? It'd be nice if they did. Maybe you guys do know that and you help people, but I mean, you know, there's websites, but truthfully what I found is foundations are a weird thing where they want to know you as a person. It's almost like, I know this sounds weird, but foundations cultivate people like the Medicis have their artists, you know, and there's like you work with Commonwealth or you work with, so very few people get foundation funding and it's part of a social thing. Government funding, it's got to be peer-reviewed stuff where you have to write these grants, you know, and then 9 months later you find out whether you get it or not.
But that question about money and funding, that resonates with you, and that would be a valuable connection to the
Yes,
conversation.
and again, I'm just being cynical and jaded that, you know, we were always chasing money, you know, and we were always interested in, but no one wants to fund health infrastructure, data infrastructure that's not proprietary. You know, they fund stuff, Northwestern Medicine will fund you to do EDW queries on the Epic electronic health software, for instance. So they're very interested in that. But it's proprietary data, it's not public data.
All right. Any last questions? All right. Thank you,
Thank you.
Joe.